Today we will be discussing nuclear imaging of the central nervous system, and the contents will be firstly discussing about the blood-brain barrier because it's important whenever you look at any radiopharmaceutical that has to be delivered to the brain or the central nervous system in general, the perfusion versus non-diffusion imaging. For just blood perfusion, the metabolic imaging with FDG, some certain diseases, and finally then also a bit of tumor imaging. So just to look at the blood-brain barrier in the healthy brain, that there is certain barriers towards the perfusion of a lot of chemicals so that toxic agents do not reach the brain. When you have a tumor or infection or inflammation, the blood-brain barrier goes through some breakdown. There's also vessel invasion, more blood vessels are being formed and they are leaky, and this could theoretically then induce the higher access of certain radiopharmaceuticals to the brain. Therefore, traditionally for perfusion imaging, the radiopharmaceuticals that we use naturally are able to cross the blood-brain barrier, so as we can see blood flow to the brain in real time, unhindered, and a certain fraction of the radiopharmaceutical. It will be lipid-soluble compounds. They should have no charge, low molecular mass, and they should also be able to be trapped into the brain according to a certain mechanism. So this follows the Lipinski rules of 5 regarding to size, charge, and lipophilicity. In the earlier days, the old technique was to image blood-brain barrier damage by using agents that normally will not cross the blood-brain barrier. And then when they do, then you know there is some damage to the blood-brain barrier, and these agents were either pertechnetate unlabeled or technetium DTPA. And then in cases of tumor and inflammation and infection, you would get the crossing of the blood-brain barrier. Currently, recently there has been some increase in the use of peptide-based radiopharmaceuticals for therapy in the brain, or just as theranostics in certain metastases. And I have here an image from a PSMA scan. It was positive in the patient's brain for a metastasis here, and then the patient was treated with actinium PSMA. And this is a classic example of a radiopharmaceutical that might not cross the blood-brain barrier to the size of the molecule, but then when it's damaged, in this case of the metastases, it will cross. So this is a more modern application of this concept. So then some diffusible agents were developed that are neutral and lipophilic, like technetium HMPAO or technetium ECD. So they are extracted efficiently out of the brain, and they are distributed to the brain as a function of blood flow. And the trapping mechanisms are different for these two radiopharmaceuticals. For technetium HMPAO, the technetium or the HMPAO molecule are reduced in the presence of glutathione, and this makes the molecule no longer neutral or lipophilic, but having a charge, and it gets stuck in the cells in the brain. And then ECD undergoes a more metabolic mechanism with esterase hydrolysis. So both of them are trapped in the areas of perfusion, and then you can image the patient. So here is an image of just a normal application to see if there is still perfusion in the brain. So in patient A, there is normal blood perfusion to the brain, and you can see the HMPAO distributing everywhere in the brain. And then in patient B, there is no longer blood flow to the brain, and then you can see that there is no distribution. I also give you the image credit down below. So technetium HMPAO is very easy to make actually, but there is often some technicalities that makes the radio labeling yield poor or the radiochemical purity. So the main concern that we have to look at is the quality of eluate from your generator. We want the primary lipophilic compound. Sometimes the secondary less lipophilic compound can be made, and this is when you have maybe the wrong quality of eluate that you used. So we want the uncharged lipophilic molecule to go to the brain. So you use a fresh eluate, your generator must be well maintained. What do I mean by this? So you cannot use a generator that has not been used in the last 24 hours. So if you come in on a Monday, you received your generator on a Sunday and you haven't eluted it, then it's not good to use because there is build-up of ground state technetium. There is very little oxidation agent, the stannous chloride in this kit, because too much also influences the labeling, so it's a very precise kit. So you have to have technetium 99M in a large quantity. So you would preferably label the second day of the week and also the second eluate of the day. So if you start your weekday on a Sunday and you want to do HMPAO, you will book the patient on a Monday and also later in the day, so that you first elute in the morning and then you do all your other radiopharmaceutical production and then you elute a second time for technetium HMPAO. If you only start on a Monday with your generator, you will do this on a Tuesday. So you use the second day of the week, the second eluate of the day. And the eluate must also not be older than 2 hours. So preferably elute freshly and label immediately. Before you then elute, you also should bring your vial to room temperature so that you can just add the pertechnetate to your vial. There should be no air entered, and you have to mix it very gently using the specific volumes in the package insert. Here I have an example of a product that asked for 2000 megabecquerel per 5 milliliters of saline added in your HMPAO kit, but different kits have different requirements. You cannot mix this vial rigorously because some of your pharmaceutical can maybe get stuck on the sides of the vial and influence the concentration. So just gently mix and let it stand for 10 minutes and then you do your quality control. Your kit also doesn't have antioxidants, and none of the saline or things that you use to prepare your kit must have any antioxidants or bacteriostatic ingredients in. When you perform QC, it must be more than 80% pure. Important to know that you have to administer this radiopharmaceutical within 30 minutes to the patient. This includes the time that you take for your instant thin layer tomography, so you have to really be quick with what you do. So already have your QC stuff prepared, and it's also a very tricky QC because you have a free strip method, because there is now a less lipophilic unwanted technetium HMPAO that you can get. You can get the right one, the primary one that you want, the technetium HMPAO that's very lipophilic. You get colloidal species and you get free pertechnetate. So there is 4 radioactive species that you can expect in your technetium HMPAO kit, of which there is a colloidal species, the free pertechnetate, the less lipophilic technetium HMPAO, and then the primary lipophilic technetium HMPAO. And based on this method, you can subtract and then finally figure out how much of your primary HMPAO is in your mixture. After you've made it, the shelf life is 30 minutes. Unless stabilizers are added, you can get methylene blue scavenger, or you can get cobalt chloride products that has a shelf life of 6 hours. Technetium ECD is the biggest difference. Of course, the molecule is different, but it is also neutral, not charged. It doesn't have a secondary non-lipophilic species, so it is more robust, the labeling. It has a shelf life of up to 6 hours because it's highly stable compared to, of course, HMPAO. And you also have a one-strip quality control method. However, the two tracers are a bit different, and they are not clinically interchangeable that much, but they measure the same sort of technique studies. They are used for the similar studies. Then the next radiopharmaceutical that I quickly want to mention, because it's going to come through the next lecture in all of the procedures basically, is of course fluorodeoxyglucose, which is the PET, positron emission tomography agent, that is called sort of the Swiss Army knife for neuroimaging. So it binds to glucose transporters, and in the brain it's one of the major, well, it is the source for energy. So it's really just an imaging metabolism of the brain, and it's very useful in multiple conditions, because all of these conditions have some form of malfunctioning of the metabolism in the brain. So now we go to the different diseases. For Parkinson's disease, you want to look at the dopamine pathways, and here we look at presynaptic and postsynaptic dopamine metabolism basically. And there is different phases have different effects. So in the early to mid stages, the striatum is mostly the one that we are looking at, but then in later phases other areas becomes more involved. And it's also important to note that there is upregulations and downregulations involved during this process, especially in the early stages. So the two tracers that we look at, the DAT scan and the DOPA-PET scans, are having some differences. So if you scan the same patients, you might get different quantification of the disease. So it's really important to note that. And then the one that you know, you should be aware of the criteria for diagnosis for that specific radiopharmaceutical. So the iodine 123, that scan binds to the presynaptic dopamine receptors, and it's most markedly present in the striatal region. That's important for Parkinson's disease. This is for single photon emission tomography SPECT scans. And you can see here that with disease progression, the striatum becomes less active. Okay. And then fluorodopa is just a dopamine molecule that is also having a fluorine 18 group for imaging, and it's relatively widely available. It measures the uptake of dopamine precursors and presynaptic dopaminergic integrity. So it's important because it follows the same metabolism as dopamine in the body. Maybe from pharmacology, you know that if you give levodopa as therapy for a Parkinson's patient, you have to add carbidopa to inhibit the metabolism of dopamine in the periphery so that it becomes available to cross the blood-brain barrier and go work where it should there. So in the case of fluorine-dopa scans, you have to also treat the patients with carbidopa to ensure that this mechanism is also deactivated for the PET scan. We used the carbidopa and not the carbilevodopa concentration because you don't want levodopa to be added a lot to your patient in the circulation and cross the blood-brain barrier and then saturate the receptors in the brain. It's just maybe not a proven thing, but we don't want to take those chances, so we literally just add the carbidopa peripherally so that the fluorine 18F-dopa can cross the blood-brain barrier. Then a tracer that I just mentioned here is also falipride that binds to the dopamine D2 and D3 receptors. There is an article that you can have a look at. It's important for diseases such as Huntington's disease. Why I mention it is because there is really good GMP manufacturing recipes available for it. It is being used in clinics, but the clinical applicability of it I don't know at this point in time. Okay, then we go to Alzheimer's disease. You have a different disease process here, which is based on the malformation of or the dysregulation of proteins. So you get tau proteins and also the formation of amyloids in the Alzheimer's disease patient's brain. And this, along with metabolic imaging, is what you would target. So I got this really nice reference from Lancet Neurology where they looked at the status, and a lot of this radiopharmaceuticals are still in research phase. So I don't want to go into depth, but it's good to know that you have just the normal structural MRI that's really used clinically and used to diagnose Alzheimer's disease. Then you have the FDG PET and the glucose metabolism that's sometimes really helpful in giving direction in this. And then, of course, amyloid PET and tau PET and the other radiopharmaceuticals are also under clinical investigation. So amyloid PET and tau PET is really being researched and will become more and more clinically available for this disease. And indeed, to target tau tangles, the FDA approved in 2020 for tau super protein fluorine 18. So this can then show you areas of higher protein misfolding in the patient's brain, and based on the regions you can then see abnormal protein metabolism and therefore a high indicator for the presence of Alzheimer's disease. Brain tumors intersects a lot with just normal tumor imaging. So for brain tumors like glioma and glioblastoma, the following tracers are very useful. The amino acid tracers, also some peptide-based tracers when the blood-brain barrier is broken. Also the glucose metabolism as always, and then also some areas for hypoxia imaging to give you more information, especially after the treatment with external beam radiation therapy or whatever the treatment may be. Then you can also image the presence of hypoxia. Here is just a small schematic to show you the glucose, of course, through the GLUT1 transporter, as we already know, all the amino acids that can show you the differences in metabolism in the brain, fluorothymidine that is there to show you the increased DNA production of tumors. These are the hypoxia agents, Ifmyso and FASA. I think FASA is the more newer category hypoxia imaging agent. And then, of course, choline, that's also used for the building of membranes, and then also in higher accumulation in these tumors that has high amount of new cell formation. But currently the state of art or the preferred ways of imaging these cancers will still be FDG PET and amino acid. In some diseases, amino acid PET is preferred for, say, radiation planning and so forth. And then also, of course, some somatostatin receptor ligands and so on, depending also on the primary disease as well as the metastases, as you can see. Then for the imaging of epilepsy, we use perfusion agents and FDG. Mostly that's the three ones that we use. Really key for me to mention to you, patient preparation is important. The patient must not be stimulated in any way. They should be sitting in a quiet room and resting and not talking. If you want to give sedation for any of these investigations, you have to give it after the radiopharmaceutical has already distributed where it should be, but you can give it before you commence the scanning. And then there's also the possibility of doing ictal and interictal administration. And then you can see during a seizure if there is increased blood flow or metabolism, and then what's the difference between during a seizure and after a seizure. And sometimes this can really also give you very important information. And for this, using perfusion agents, that is positron emitters, or FDG for metabolism, gives you a higher resolution, because sometimes these epileptic foci is really small. So if you have access to PET, you should rather be looking at some options for positron emission tomography in these instances. Then cisternography is to look at the central compartment leakage, and then also damage and obstruction of the cerebrospinal fluid. It's quite a dangerous procedure to perform, so you have to make sure that the radiopharmaceutical that you use is really safe for this type of administration, because you will go past the blood-brain barrier and inject it inside the spinal cord, and then there is no barriers of protection for the patient, and it has had really severe side effects in the past. So again, sterility and the presence of pyrogens should be really looked at, and then you can use DTPA based compounds. Okay, so for that there is SPECT options and PET options, but mostly the safest one would be to order indium DTPA directly from the manufacturer. That is the preferred one if you can get that available. So you use indium 111 DTPA from the manufacturer. It has a longer half-life, and you have to clearly communicate with them that it's being used for cisternography. But technetium 99M DTPA can be labeled in-house, and then there's also some research being done on PET type of isotopes. If you want to do technetium DTPA, and I would strongly not advise you to do it in-house, because like I said, the procedure is quite dangerous. The half-life is too short for some studies, but you can image and see some leaks of the central nervous system. Other studies that is being done is to provide a patient with nose plugs and see if there is any leakage of cerebrospinal fluid through the nose, and measuring it over time. But you have to have the right kit, so there should only be using the calcium sodium free salt, because the calcium prevents the removal of calcium and magnesium out of the central nervous system. So most of the DTPA kits that you can get on the market is not okay for this cisternography procedure. Okay, so if you want to do it, you have to clearly make sure that the kit that you use is okay for the cisternography procedure. The pH of your radiopharmaceutical cannot be less than 6, so you have to measure your pH. There should be no preservatives added to the kits. You cannot inject more than 1 milligram of your kit into the patient, so the amount of active ingredient cannot be more than 1 milligram. There should be no pyrogens. Pyrogens are small chemicals that causes a fever reaction, so you have to test with an endotoxin test kit for the presence of pyrogens if you make it in-house. So I clearly want to again say you cannot order any DTPA kit, add technetium to it, do an ITLC, and then inject it into the patient for cisternography. You have to do extensive QC, and you have to order the right kit, and you must make sure that everything is in order before you inject it. There are, of course, many more radiopharmaceuticals that we could discuss, but I try to just pick some of the most important ones to give you just a broad outline. Otherwise, this lecture will become too long. There is a lot of research being done, and yeah. If there's anything I missed that you would like me to discuss separately, you can add a comment. So yeah, please like and subscribe, comment with suggestions and requests, and then also I just have to disclaim that all images that I've used were either from referenced articles or were created on biorender.com. I have a licensed version of that. Thank you so much for your attention.